Hello guys, welcome to the Cortex Medicine, and this is the 30th episode of Cortex Medicine channel. And the topic of today is the hypertension, and I am the theboggusdoc. So, in the INICET May 2025, there was a question that a 58-year-old male present to UPSC for a routine checkup, and his blood pressure on two separate occasions are 148 by 90 and 152 by 96. He is asymptomatic and has no known comorbidities. What is the most appropriate next step in the management according to current hypertensive guidelines? First thing that the examiner is mentioned, THC means he is asking about the Indian guidelines. Second, he also mentioned the two separate occasions, mean talking about two different days. So in the 2022, there is a guideline in India from the Indian Hypertensive Control Initiative that was uh, specific for Indian population. So they mentioned that if the systolic blood pressure is 150, 159 or diastolic blood pressure is more than 90 by 99, check on different day as mentioned in the question, and if it's still elevated, start treatment. So the question is already mentioned about the two separate occasion and the BP is more than 140 in the two separate occasions. So answer should be start the amlodipine. Now you have to think that if the systolic blood pressure is more than 160 at any occasion in the same day, you directly start the antihypertensive, and the BP is more than 180, you have to refer to a patient to a specialist. Blocker is not added in the guideline, and beta blocker is only indicated in the according to Indian guideline when the patient has heart attack in the last 3 years. Also, in the guidelines, we have to first give the amlodipine and then telmisartan and then increase the telmisartan. First amlodipine, then telmisartan. After that, telmisartan 40 to 80 mg in double dose, and then you have to double the dose of amlodipine, not in the second time. And then the third medicine, you have to add the chlorthalidone. As you know, this is a diuretic. If the chlorthalidone is not there, you have to add the hydrochlorothiazide. Exercise 2.5 hours per week, and salt under 1 tablespoon per day. So answer should be B. There is some definition that is important from the point of this topic, that what are the hypertension, what is the hypertensive emergency and what is the hypertensive urgency. Sir, hypertensive emergency and the hyper urgency, the BP value is same, it is more than 180 by 120. If there is a new onset or worsening organ damage, then you have to include the patient in the hypertensive emergency. If there is no without clinical laboratory or instrumental evidence of acute hypertensive organ damage, uh, okay, then you have to think about the hypertensive urgency. And what are the organ damage like the hypertensive and acute stroke, ICH, and acute coronary syndrome, pulmonary edema, aortic dissection, acute or rapid progressive venous failure, sympathetic crisis, eclampsia, severe preeclampsia. These are the conditions that include the in the organ damage part. There is two terms that always confuse us, that what is the malignant hypertension, what is the accelerated hypertension. Sir, malignant hypertension in the accelerated hypertension is a subpart of the malignant, is the subpart of the hypertensive emergency. Simple we can say this, the what is the umbrella, it is the hypertensive emergency is the umbrella, and under these two terms comes malignant hypertension and accelerated hypertension. The malignant hypertension specifically include the retinal part, means changes in the eye, what the by the papilledema means or the exudate means. If in the malignant hypertension, if you see the histopathology, you have to see the fibroid necrosis of the arteriole. So difference between malignant hypertension and accelerated hypertension is the papilledema. It is the this is the eye changes. In the accelerated hypertension, you also see the worsening organ damage, but lack of papilledema is there. Now the new update in 2024 guideline, that we removed the term hypertensive urgency and changed it to the asymptomatic markedly elevated BP. So asymptomatic markedly elevated BP means the BP is more than 180 by 120. 110 is also included. Okay, 120 here in this guideline we included 110 also. Okay, and the not markedly elevated inpatient BP means asymptomatically elevated BP. So now we have two, one hypertensive emergency, one patient is asymptomatically markedly elevated BP or asymptomatically elevated BP only. The markedly term is only used when the systolic blood pressure more than 180 and diastolic is more than 110. So what is the 2023 guideline in the ESC guideline of 2023 have the normal BP, high normal BP and hypertension patient, but in the 2024 guideline, 2024 update, we have the non-elevated BP, elevated blood pressure and the hypertension. Earlier it was normal, high normal and hypertension. Now we have the non-elevated, elevated and hypertension. The non-elevated is more than 120, 70. Elevated is 120, 139 or 70 to 89. And hypertension is more than 140 by 90 according to ESC guideline. So earlier, if you see the 2023 guideline, they focused on the early lifestyle modification point. But in the 2024 guideline, the ESC focused that if the patient have any cardiovascular risk, if the patient has high cardiovascular risk or organ damage, you can start the early pharmacological treatment if the BP is in the elevated range, if the 120 to 139 or 70 to 89. Remember point, lifestyle modification was first priority in the 2023 guideline, but in the 2024 guideline, they said that if the patient has elevated BP and if the patient has higher cardiovascular risk or organ damage, you can start the early pharmacological treatment in the elevated range also. They also focus on the fatal and non-fatal cardiovascular risk outcome rather than just BP. Means they are not focusing that the BP should come below the 120 or 1 by 120, 180, but focus on also fatal and non-fatal cardiovascular disease or symptom also come down. So what is the home blood pressure that is counted? It is the BP, same non-elevated is 120 70, but in the elevated part they consider the 135 to 85. Okay, not 139 or 89. It is the 135 85, and the hypertension is more than 135 85 at the home. If you measure the BP at home, the hypertension defined is more than 180, 135 or 85. Now the confusion term is the white coat hypertension. It is a simple term. White coat hypertension means if you are taking the blood pressure at the in the office, BP that is above the threshold for diagnosed hypertension in the office means if you are counting the measuring the blood pressure, it is above the threshold. But if you are counting in the home or ambulatory setting where you are resting, the blood pressure is below the threshold. Simple means the blood pressure is more than 140 by 90 in the office, but 130 less than 130 by 85 at home or ambulatory daytime. So what are the how the blood office blood pressure measurement is done? You have to measure the blood pressure after sitting the 5 minutes. But when you practice in the emergency setup or periphery setup, the patient comes and said कि सर मेरा BP ले लीजिए. They don't want to wait, but insist. You can insist them to wait and say कि सर 5 मिनट बाद BP ली जाएगी. Just wait for 5 minutes. After that, use a validated device with appropriate cup size and place the BP cuff at the level of heart. After that, measure the BP 3 times. Okay, this I included this chart because of this, that you have to measure the BP 3 times, 1 to 2 minutes apart, and average the last two reading. Okay, I included this chart because of this only. After that, you have to obtain the further measurement if the reading differ by more than 10 mmHg. Measure BP in both arms at the first visit. Record the heart rate and exclude any arrhythmia by pulse palpation, and assess for orthostatic hypotension also for the first visit. So you have to see that there are 2 3 things that important for us. First is the orthostatic hypertension by this, and what are the BP cuff size. So the bladder length should be around 75 to 100%, and the width is 35 to 50% of the arch circumference. Just rectify this. Second, the ESC guideline included 2 new score. It is a score 2 and score 2 OP. Means if you are measuring, if you are this, you have to start the hypertensive medication. You have to measure these two risk prediction models, score 2 and score 2 OP, that is developed for the general population to predict the 10-year risk of the cardiovascular disease. But simple, if you say that a patient have high risk condition, you have to start the hypertensive medication. But in the normal population, when you start the hypertension medicine, when the patient have score 2 or score 2 models have higher side that predict the 10-year risk of cardiovascular disease. So there is a secondary hypertension. You know, the secondary hypertension is more common than primary in the young onset. So if you see primary aldosteronism, you have to see the aldosterone to renin ratio In the renovascular hypertension, you have the renal Doppler ultrasound or abdominal CT. If you think about the pheochromocytoma, you have to do the 24 urinary or plasma metanephrine and normetanephrine levels. In the obstructive sleep apnea syndrome, you have to do the overnight ambulatory polysomnography. Renal parenchymal disease, Cushing syndrome, you have to do the 24-hour urine-free cortisol or low-dose dexamethasone suppression test. In the thyroid disease, and so on and so on. The important one is the primary aldosterone. uh, Cushing syndrome, and pheochromocytoma. Remember these three by heart. Now, if you see what are the target, so target for the specific disease, like if you have the compelling indication, like the severe eclampsia, or pheochromocytoma with hypertensive crisis. In these three, four diseases, you have to decrease the systolic blood pressure by the 140 in the first hour itself. And if the patient have aortic dissection, the symptom of aortic dissection, with the sudden tearing chest pain that ready to bed, it is the systolic blood pressure is the less than 120 in the first hour itself. And for rest all other diseases, you have to decrease the BP by 122, 129, and 70 to 79. Simply we can say by the less than 130 to 80. यहाँ पे एक जो important point है, what are the important point that patient the it can be possible that patient the examiner can give the eclampsia or pheochromocytoma patient in the INICET like question, but in NEET PG they will consider the malignant hypertension only, and the malignant and urgency, hypertension, emergency, and urgency. And most, I think the most, if I saw the previous year question, the most common asked question about the blood pressure control is the ischemic stroke. Then I covered that all topic already in the ischemic stroke part. So what are the preferred parenteral drug? Remember the hypertension, there are multiple drugs. Just remember that these are the drug that can be used in the that can be used by the parental route. Remember these. That's why I included the mean of include these is not about to rectify all. But remember these, just अपनी आइस के नीचे से इसको निकाल लो, आइस के नीचे से एक बार लुकआउट कर लो, देख लो इसको कि uh, these are the IV drugs that can be used in the hypertensive emergency. Now about the stroke, you have to decrease the blood pressure by, if the blood pressure is more than 220 or 120, you have to decrease the blood pressure in the first hour by the 15%. If you are planning for, remember these are these things are the confusion now. Simple, एक patient का you are planning a patient for the thrombolysis, imagine. So what is the target for the BP, and what is the maintenance BP? So target BP for if the patient if you are planning a patient for thrombolysis, the target BP blood pressure before या prior to thrombolysis is 185 to 110. Simple है कि patient, if you are planning a patient for the thrombolysis, तो आपको BP का target क्या रखना है, blood pressure का target क्या होना चाहिए, should be less than 185 by 110, but you have to maintain the BP by the 185 by 105. If you someone want to confuse you by the 5 points, they can be. So remember this, the maintenance BP is less than 185 by 105 for the 24 hours. Don't confuse in this. And the stable patient who remain hypertensive even after the more than 3 or 3 days after an acute ischemic stroke, you have to consider or initiate or reintroduce the BP lowering medication in these patients. Now the antihypertensive drugs, remember these are the diuretics. Okay, these are the RAS, there are the sympathetic inhibitors, that is also the central sympatholytics, also the CCB and vasodilators. I included little points from these topics. So if you see diuretics, these diuretics also increase the thiazide, increase the potassium. Okay, or not? Thiazide decrease the potassium, and furosemide also decrease the potassium. Okay, back to study. In the diuretic part, if you see that thiazide, high ceiling diuretic, and potassium spike, there are three diuretics. Okay, so in the diuretic part, thiazide also decrease the potassium. A high ceiling loop diuretic also decrease the potassium. Thiazide, or the thiazide increase the blood uric acid. So it is not preferred in the gout. It also lipid and it also sugar. So less preferred in the diabetic patient. High ceiling diuretic, preferred in the fluid overload state. In the RAS, you have to remember the ACE inhibitor, AT1, and direct line inhibitor. ACE inhibitor and ARB are the preferred in the CKD patient, but with the great caution. For the ACE inhibitor, remember it causes the side effect of cough. The important molecule is the bradykinin, and ACE inhibitor increase the potassium, and angiotensin also increase the potassium. There is a direct renin inhibitor. Remember the term aliskiren. It is a direct renin inhibitor. For the sympathetic inhibitor, you know the beta adrenergic blocker and alpha plus adrenergic blockers. These are non-specific that can be used but contraindicated in the asthma and COPD patient. You know the labetalol, famous drug used for the pregnancy in the eclampsia patient. There is also sympathetic inhibitor like the alpha adrenergic blockers and central sympatholytic. Remember the name clonidine and methyl dopa. Methyl dopa is a alpha 2 agonist, and it central sympatholytic cause rebound hypertension. The alpha adrenergic blockers like prazosin used in scorpion bite and phentolamine is used in the pheochromocytoma. First give the alpha blocker and then they give the beta blocker drug. It is the first. If the alpha adrenergic blockers have the side effect of first drug hypotension. For the antihypertensive drug, the calcium channel blocker is the verapamil, benzodiazepine is the diltiazem, and dihydropyridines are the nifedipine and amlodipine. You remember the amlodipine, most widely used. The side effect of amlodipine is the pedal edema, and the nifedipine also causes the reflex tachycardia. There is a vasodilator, like the arterial dilator and the arterial plus venodilator. Nitroprusside, you know, it increases the CGMP, and for the arterial dilator, you know the hydralazine. It causes the lupus, and minoxidil, it is a potassium opener, remember. And these are the arterial dilators that you can use that can cause reflex tachycardia. Remember the diazoxide, it is a arterial dilator. You know the famous question that beta blocker and verapamil is not cannot be given together because of risk of severe bradycardia plus AV block. There is a new drug, lorundrostate. Okay, it is a novel aldosterone synthetase inhibitor. You can reduce the 24-hour blood pressure. So how will you start? What are the pharmacological management? You have to start first with the low dose double combined therapy. Remember what is the preferred? It is a double combined therapy, either ACE inhibitor, CCB or diuretic, and you have to measure every 1 to 3 months and increase the if the patient is not normal, then you have to increase the dose from for the low dose triple combined therapy. Then you have to increase the maximum tolerated triple combined therapy. So on and so on. For the what are the initial monotherapy preferred in the patient? If in the elevated BP category, if there is a patient have moderate to severe frailty, if the patient has symptomatic orthostatic hypotension, and if the age is more than 85 years. So what are the conditions? That systolic hypertension with wide pulse pressure. You remember these: fever, thyrotoxicosis, aortic regurgitation. What are the first hypertension? Primary hypertension, actually. Primary hypertension cause, it the most important factor is the heritability, and the second most important point is the obesity and weight gain. Now, what is the resistance hypertension? Asked multiple times in the NEET PG and INICET, it is the BP remains above the goal despite using more than 3 antihypertensive agent, but of different class. First point is a different class. Second point, in the different class, one class should be from diuretic. One class should be diuretic, or one drug should be from the class of diuretic. So what are the treatment in the lifestyle modification to manage hypertension? You have to reduce the weight, dietary salt reduction, adopt dash diet dietary plan for more than at least for 8 weeks, moderation of alcohol consumption, and physical activity about the 30 minutes per day or 150 minutes per week for of the moderate intensity. Dietary salt reduction, it is a 5 gram per day, or you can say 6 gram NaCl per day. Attain and maintain BMI less than 25. For the weight reduction and dietary salt reduction, which is the better? It is the weight reduction that is better. Potassium, the potassium guideline in the DASH is potassium 3.5 gram per day minimum. Because in the DASH diet, they included the fruits, vegetables, low-fat dairy products with the reduced content saturated and total fats, and also diet rich in potassium, calcium, and magnesium. These three nutrients. So, what is the drug that is preferred in the hypertension with diabetes? It is the ACE inhibitor, ARB, CCB, but thiazide not preferred because I told you preferred but not so preferred because of it also cause the hyperglycemia, as I told you, and beta blocker is not preferred because of it can mask the hypoglycemia. In the diabetic kidney disease, I told you that ACE inhibitor or ARB is preferred, especially if the patient have albuminuria and the GEGFR is more than 30. But remember, what is important in the ACE inhibitor ARB, that if you are giving the ACE inhibitor ARB, you have to see for the potassium and the creatinine value. If the around 0.45 or zero point 0.5 potassium is approved in the 3 to 4 days, if you start the ACE inhibitor ARB, and not more than that. So patient is on CKD and with non-diabetic, you still start the ACE inhibitor ARB, loop or CCB. For the portal hypertension, you give the beta blocker. If the patient have upper limb or lower limb BP difference, you have to consider the disease co-occlusion of aorta. There is a term young onset hypertension. According to ESC guideline, they include the young adulthood in the age of 18 to 40 years, and in these patients, secondary causes are so common. For the young female, they told that what is the most common cause of drug-induced hypertension? It is the combined OCP. Now there is a special term, the severe acute hypertension in pregnancy, but without preeclampsia. It is the BP more than 160 by 110 associated with adverse maternal and diastolic child outcome. Okay, so I hope we covered this topic extensively. Now you can solve the previous year question from this topic. Also, read this topic from your notes. Thank you. Keep following, keep sharing.